Good evening to all the aspirants present here. Good evening, Dr. Anand Joshi, sir.
Good evening, Fatima.
Yes, sir. So you can share your PPT. We'll be starting, and many more aspirants will be joining us.
Right. Thank you.
So, aspirants, today's topic is urinary medicine and AIDS, and the speaker that we have here is Dr. Anand Joshi, sir, who is a consultant, intensivist, and physician at Gamman Hospital, Hyderabad. So, you may take over. Thank you.
Good evening to all, and welcome to another session of a series of talks for your preparation for MRCP preparatory course for part one and part two. Um, Today's topic is genitourinary infections, which is very common and commonly called as a sexually transmitted disease. And this topic you will encounter more so in history taking when you're doing at your PACES course. And there will be a couple of few questions you would come across in your theory part also. Important are the infection specific, which are namely gonorrhea, chlamydia, syphilis, which I will be covering in today's session. HIV and AIDS is a very vast topic and will be covered in tomorrow's session. One of the important things when you are dealing with sexually transmitted disease, especially from the exam point of view, you will be required to acquire an history taking examination and its investigations that needs to be explained to the patient, and you may get a table or a station for the same. um, Here the importance is given to how accurately you're taking the history, and the key components where you get marked are in a history taking. What are the examination features specific to that disease you are having a differential, and what are the relevant investigation you will be sending. It is very important as a general practitioner or as a part of the MRCP that certain specific thing about the investigations you are aware. Now, because this is quite a sensitive issue, building a rapport with the patient becomes very important. You have to ensure in your discussion the confidentiality, and you have to use a very non-judgmental language, especially when you're talking to a female partner, a female patient, or a male patient, or a male partner, or female to female, or female to male. The general salient point when you're talking or trying to elicit the history is to have an empathy in your language. Your non-verbal communication, like your body language, your tone, your posture, plays a very important role here. Giving a signposting and gaining a consent before you start asking the direct question is very important. The opposite person should know what's coming in. To avoid any controversy and to avoid any kind of judgmental approach, always use gender neutral term. For example, instead of asking your wife or your boyfriend or your girlfriend, you should just name it as a partner. Always look out for the risk for the sexually transmitted disease, because risk-based screening even in an asymptomatic patient is important. So these salient points are not only important for your exam point of view, but also in your day-to-day practice when you're sitting in an OPD and when you're trying to elicit this kind of sexually transmitted disease, it becomes very, very important. Generally, you should start suspecting that you're dealing with a sexually transmitted disease uh, with certain specific complaints. So, when a male patient comes with, say, penile discharge or a dysuria or a scrotal pain or swelling, abdominal or pelvic pain or anal symptom, you should think that you are dealing with a sexually transmitted disease. Each complaint, you should get a bit more in detail. Like, for example, when you are talking about a penile discharge, you should be asking them about the color, the duration, the amount. If it's a dysuria, you should ask specifically whether it's just at rest or whether during passing urination. Um, Scrotal pain is a very important because even though you are thinking of sexually transmitted disease, but spontaneous torsion of testicles are also possible, and that becomes a kind of emergency. Anal symptoms, don't forget that unnatural sexual acts or actions, especially with the same-sex people, is possible, and hence you should always keep that thing at the back of the mind. Always evaluate in detail all the ulcers, all the rashes, all the warts in the urogenital and oral area. When it comes to the female symptoms, vaginal discharge, soreness, dysuria, pruritus, same ulcer, rash, wart, abdominal pelvic pain, postcoital bleeding or pain during intercourse, menstrual history, and contraceptive history are important. Beside this, general systemic symptoms like fever, malaise, night sweats, sore throat, myalgia, arthralgia, conjunctivitis, mouth ulcers, and sometimes different organ involvement included and not limited to liver, particularly the jaundice, should be evaluated for STDs. Now, once you know you are dealing with STDs, sexual history becomes a very, very important. You have to be very, very discreet. You have a lot of empathy, and you should always have that non-verbal communication posture. And you should nail this even in exam or in your real life. Then only the real history would come out. You shouldn't be hesitant in asking. Always make sure you ask about the sexual contact and partner's gender. Um, you should also ask about whether they are the same partner, they're casual or an unknown or professional sex workers, whether the use of any condoms were used, whether the number of partners you're talking about, natural, unnatural intercourses, all involvement of sexual industry or previous history of any STDs and HIV testing, and about the vaccinations. These you should ensure that when you take a sexual history, if you are covering all these points. A couple of sometimes background history gives clues, medications, allergy, use of recreational drugs, illicit drugs. Um, if none of them, at least having some tattoos or blood donations have been made. So during that time, they would have acquired these diseases, especially the hepatitis. Smoking alcohol doesn't necessarily mean that the person is got then more of a sexually transmitted, but this form an important starter for asking more deeper into the various habits, like are you smoking, do you take alcohol, do you take any recreational drugs, etc. Travel history sometimes becomes a very, very important. Particular notorious places you all know should be kept in mind, and support systems and expectations can also be gauged. Whether the person is alone, whether the person has a good supportive family, that would also gauge not only in terms of knowing the history, but also when you inform them and when you are treating the person, they might require some family or system support. Formulating a plan is important. Once the history is taken, you have to clearly uh, verbalize that this is the sexually transmitted infection is likely cause. Don't beat around the bush. You have to mention the word, yes, we are looking at sexually transmitted disease or sexually transmitted infection. You need to tell in advance with the proper confidentiality, and you need to win over the trust, and you need to discuss in detail what clinical examination you are going to do. There should be no surprises for the patient, and that should prevent you from any embarrassment or any lawsuit um, the patient might think of taking upon you, because you have already discussed in detail the clinical examination. Blood investigations also, it's a patient's right. And what investigation? You just can't say that we are going to do some kind of screening. No, you have to specifically say, we am going to screen for HIV, I'm going to screen for sexually transmitted infection like gonorrhea, chlamydia, or syphilis. You have to mention that, and that's the patient's right. Sometimes the patient might come up saying that, no, I had an HIV antibody testing done and it was negative, in which case you might have to explain a little bit in detail about what an HIV window period is and importance of repeating the testing. Don't forget to talk about the partner. Don't forget to inform the partner or the involvement of partner, because that is your moral duty if the patient turns out to be having this kind of any kind of infection, particularly in HIV. And this is important from the public health point of view also. You also have to explain about the follow-up results and the treatment. Some of the features you need to remember when you're investigating. For men, when you're asking for a urine sample, the first catch urine is important for chlamydial infection. The midstream urine is what you're looking when you're looking at any other urine infection. Urethral, rectal, or throat swab are important for gonorrhea and chlamydia. When you're asking a woman for investigations, its midstream urine is important for pregnancy test. Vaginal swab and is important for candida and trichomonas. Cervical deep swabs for gonorrhea and chlamydia, and urethral and the throat swab are also important. Other relevant tests you would do are if there are any skin lesions for the herpes or the syphilis, um, hepatitis screening, particularly hepatitis B and HCV, HIV testing, depending upon the suspicion and depending upon what window period you are expecting, you can either go for a rapid test or a PCR test. And if you're looking at the syphilis, then syphilis serology, especially ELISA and fluorescent treponemal antibody or TPHA. So in summary, a detailed history gives you a strong foundation of sexually transmitted diagnosis, includes sexual, systemic, social, and medical aspects. And there should be, it's not that one size fits all. So it's a tailored investigation based on what the patient is complaining. Here, confidentiality and the communication are key for the patient to open up. Now, having taken this history now, we will go to our three other individual sexually transmitted diseases. So the first one is gonorrhea. Now, gonorrhea is caused by Neisseria gonorrhoeae. It's a Neisseria gonorrhoeae infection. It is a intracellular diplococcus seen under the microscope. Uh, it is primarily transmitted from the tip of the penis for the male. So an intimate physical contact is very, very important. It just doesn't get contact from on the fomite or on the surface. It is found in humans only, and particularly in the human urogenital tract. Now, because depending upon what kind of sexual intercourse they are doing, if it's natural, then you are looking at the disease or the symptoms at the tip of the penis for men and vaginal or cervical lesions. However, if history suggests that there is a possibility of unnatural sex, then you are looking at rectum and pharynx. Uh, Presence of Neisseria gonorrhea or gonorrhea occurs in a conjunctiva, especially when you are looking at the um, vertically transmitted in the babies or the neonatal cases. Gonococca is a very, I would say, a very, very fragile organism, and it is highly sensitive to drying. It just dies. It doesn't survive on the surface. So fomite transmission is extremely rare. Almost 50% of women and 10% of men will be asymptomatic. So you may see some vague symptoms, but then if these are the high risk population, high risk activity, then it becomes essential for you to screen them. Usually the incubation is from 2 to 14 days, and patients are symptomatic by end of 5 days. In men, it presents as a very anterior urethritis because it presents mainly at the tip of the penis, and hence the initial sample of the urine is important. It comes as a dysuria or a urethral discharge. If it gets more ascended from there, then you may see the complications of epididymitis or prostatitis. In people with having an unnatural intercourse, proctitis in form of pain, discharge, and itching will be the presenting features. For women, the primary site is endocervical canal, and vaginal discharge, pelvic pain, dysuria, intermenstrual bleeding are the important symptoms. Again, if since there are 50% of the women are asymptomatic from the primary disease, you may end up with the complications of Bartholin's abscess or Friggs-Curtis syndrome or infertility. In fact, a lot of women with infertility were discovered to have this infection. Um, Rectal gonococcus for the women, they are usually asymptomatic. Pharyngeal, they are also often asymptomatic. Neonatal will have this ophthalmia neonatum. They may present as just as first presentation as an arthritis, rash, fever, malaise, more common in women, and you might have to dig around a little bit more, or any high risk behavior should raise the suspicion of the disseminated gonococcus. Uh, Diagnosis is generally by NATs, but sensitivity of culture is in a selective media is more than 95%. NAT is a very non-invasive and very commonly used. It is sensitive, but there are risk of false positive test. Microscopically, it is seen as an intracellular gram-negative diplococci. Disseminated gonococcus can be isolated from blood and sometimes in a synovial fluid, especially when you're dealing with an arthritis. When you are dealing with a gonococcus, you should also screen for chlamydia, trichomonas, and syphilis. Uh, Treatment, if you're very strong suspicion, then you can start treatment empirically just based on the gram stain. If the microbiology reports say it's a diplococci, then just think of gonococcus. In UK, ceftriaxone 500 milligrams intramuscularly is the dose, and if they are any alternative would be amoxicillin, ciprofloxacin, or ofloxacin. However, CDC recommends giving or adding azithromycin 1 gram stat dose as a treatment of choice. There has been resistance noted to most of the antibiotics, so that needs to be followed. So hence the culture is very important if possible. Complicated infection need longer duration of treatment. Reassessing and repeating culture after 72 hours is also important. The contact tracing becomes essential in these cases. So in summary, it's a common STI with serious complications. That's gonorrhea. Early diagnosis and treatment is a key. Rising antibiotic resistance is a concern, and pattern notification and follow-up are. Any questions so far? The next STI is chlamydia. So chlamydia has got a worldwide distribution, and it's very common, especially younger people. Almost 14% of the young UK people have chlamydia as an infection, and it coexists with gonorrhea. So if you're treating with a gonorrhea, we will know in later that the treatment is a lot of overlapping of the treatment in gonorrhea and chlamydia. 20% of men and 40% of women with gonorrhea also have chlamydia trachomatis. Major cause of non-gonococcal urethritis in men is again attributed to this disease. It's more often asymptomatic than gonococcal. So up to almost 50% of the men and 80% of the female are infected are asymptomatic. The importance is because they are asymptomatic, they become asymptomatic carrier, and they are responsible for the spread. Hence, it has also been introduced in a national screening program. Again, the features would be anterior urethritis, ascending infection as epididymitis, proctitis, and a reactive arthritis for men. For women, it would be again endocervicitis. Mostly, as it mentioned, it's 80% of them are asymptomatic and may present with some discharge or intermenstrual or postcoital bleeding or abdominal pain. Rarely they do have come up with the complications of self-inditis and infertility. Neonatal will have this mucopurulent conjunctivitis or sometimes pneumonia. It's very rare, and reactive arthritis. Now, this is an obligate intracellular bacteria. Again, NAT is the standard of uh, care investigation. It has almost 95% sensitivity. Cell culture is 100%, but it's expensive and it takes long duration of trial. Indirect test like DIF, direct fluorescent antibody, or ELISA, they are available, but they are less reliable. Can be used for screening. For the specimen, men's first void urine or urethral swab, and women's endocervical swab is preferred. There is a ligase chain reaction is an alternative to PCR for the detection of chlamydia. Uh, Treatment wise, it's a first line of treatment is azithromycin 1 gram single dose or 7 days of doxycycline. Alternatively, you can use an erythromycins. Tetracyclines are contraindicated in pregnancy, so that becomes a problem. Test of cure not routine unless symptoms persist. So you can just give one shot and then you can expect that you don't need to follow up for these patients. NAT can stay positive for 5 weeks. So even the patient is cured, the NAT may be positive. If symptoms persist or reinfection suspected, then only retest. Otherwise, it's not advisable or it's not going to be helpful. All the corresponding sexual contacts must be notified and treated. So chlamydia is a highly prevalent and more often asymptomatic as compared to gonococcus. And it does cause, as a complication, infertility. Here, the accurate diagnosis and effective treatment is available, but it's difficult because most of them are asymptomatic. And screening and partner notification is crucial for the control. Any questions on this? They're very short and straightforward, so I don't think there should be any problem. Now, let's talk about the syphilis. Now, syphilis, as they say, was a disease of past. That means in 60s, 70s, and 80s, it was very, very prevalent. However, with the surgence of HIV and its complication, this disease has gained back its importance because a lot of patients with syphilis, HIV, do get syphilis and they have a rapid complication rate. This again has a very significant public health impact. It is either acquired or congenital, and it has its various stages. Now, the early stage, it becomes very straightforward for the diagnosis and treatment. However, as it disseminates, and if the presentation we see is mainly in the late, then you are looking at a vast differential as these patient comes as multi-organ complication and they are potentially fatal. The mortality is very high. This again, the resurgence of the disease is because of the HIV and its related activity. It's caused by a spirochete named Treponema pallidum, and it transmitted with sexual contact and transplacental. The entry of spirochete is important. It has to breach in a squamous or columnar epithelium. So there has to be a really injury happening for the spirochete to go in. As I said, there are primary, secondary, latent, tertiary syphilis. In latent, we have early and late, and then we have a congenital syphilis. Usually, the incubation is from 10 to 90 days, average with 21. The classical presentation for a primary syphilis is a firm penile ulcer, which is painless, called as classic chancre. This is followed by a regional lymphadenopathy, which is again is a painless. Now, chancre will heal spontaneously in 2 to 3 weeks. Once that time or that chancre is gone, the secondary syphilis may occur within 4 to 10 weeks of the primary lesion. Now, this has more systemic effects, mainly fever, malaise, sore throat, or arthralgia. 50% of them will have lymphadenopathy and rash. The classic snail track ulcers or condyloma lata is what you will be seeing. And if the disease has rapidly disseminated and involved neurology, then encephalitis, encephalopathy, and the various neurological signs might be the presenting features in almost 10% of the people. If the patient has gone through this primary and secondary, has sailed through it, sometimes they may not get diagnosed and they end up with a latent syphilis. Now, early latency is considered up to 2 years, and the late latency is after 2 years, and all of them may be asymptomatic. Now, the importance of this latent syphilis is that the risk of recurrence or progression is very important. So the patient might have had a couple of years back these symptoms, but when they are now presenting to you as in some multi-organ failure state, and you are still not aware that why this is happening. So history taking becomes an important here. When the patient gets with a later complication of a gumma formation, especially in the skin and the bone, or the gummas are found in the liver and testes, then we call them as a tertiary syphilis. Involvement of the cardiovascular system, in particular aortitis or aortic root involvement, or presence of or occurrence of neurosyphilis is considered as tertiary syphilis. From mother to child transmission, congenital syphilis occurs as early as 2 to 6 weeks, presents as a nasal discharge or any lesions. Later, as the child grows more than 2 years, then they have these classical features, Hutchison teeth, dental and bony deformities. And as they grow, adult type of tertiary features might be presentation. Spirochetes are classically diagnosed based on the dark ground microscopy. Other blood investigations, which are treponemal specific, are ELISA, fluorescent treponemal antibodies, treponema pallidum hemagglutination, or TTPA. These are specific for the treponem. There are previously used to be VDRL and RPR test, which are very non-specific, and sensitivity and specificity is very less. False positive are very common, especially when you're doing VDRL test. CSF examination for syphilis is indicated when there are any neurological symptoms or there are very high VDRL titers. Also, if the patient is concomitantly HIV infected, then and has neurological symptoms, don't forget to screen for syphilis in a CSF examination. Procaine penicillin for 10 days is the still treatment, and it will really give a good results. If it's a late presentation, then it has to be extended for almost 3 weeks. Those with the penicillin allergies can have an alternative for doxycycline or erythromycin, or you can always, for instead of procaine penicillin, you can use benzathine penicillin. Now, in India, you don't get these things easily now because I don't know any manufacturers, but definitely in UK or in overseas places, we still do use benzathine penicillin. Something you need to know while you are treating is the Cherish-Hexmer's reaction. It almost acts is seen in 50% of the patients and 90% in the primary and 90% in the secondary patient. Usually, after the antibiotics are given, approximately in 5 to 8 hours post treatment, there is a sudden rise in the temperature. The patient becomes restless, headache, malaise, and you may see the patient seems to be deteriorating. But that's not the case. The treatment or the antibiotic should not be withheld, and the symptomatic treatment with IV fluids, paracetamol should be given to this patient and managed. Regular serology as a follow-up is very, very important. If the patient is caught up in an early and treated early, then there is a good prognosis. But once the patient has gone in secondary, tertiary, or cardiovascular or neuro involvement, then the reversibility is very, very unlikely. Partner notification and again screening is vital for these patients. So again, syphilis is a major public health concern, and early recognition and treatment are important. Here, syphilis has become important because of the involvement of co-infection with HIV and rapid dissemination and multi-organ involvement in an HIV patient. So follow-up is very crucial for this patient. So that brings to the end of my talk here. Any questions? We will be covering HIV in detail tomorrow. Yes, Sajratul, you want to say something? So if there are no questions, happy to close the session today.
Aspirants, you may ask any question.
These are straightforward infective information. Main thing remains is your initial history taking. And that's where the scoring is important. Yes, you need to know these other infections in detail. That's the reason I have touched in. But the main thing is in the history taking, especially for the PACES patient.
Sir, one question.
Yep.
Early syphilis, it is associated with benzathine penicillin only single dose. What is it?
No, so that's benzathine penicillin, benpen. I think it almost we need to give it for 10 days. They say as a single dose, but more often than not, we end up giving that. So it is mentioned in the books that one shot would be enough, but on practically we have seen that we at least give it for 5 to 7 days, or at least 10 days for that.
Yes, thank you, sir.
I was actually waiting for this question. Nobody's asking me this question because benzathine penicillin, I don't know when we have used it last. But yes, overseas people do use it.
Syphilis in pregnancy.
Syphilis in pregnancy is a very tricky thing because you can't use much in terms of tetracyclines. If you don't have benzathine penicillin, then it becomes a very, very challenging affair. Diagnosis again is very, very challenging here, because if the involvement of the babies, the miscarriage, and the chances of abortion goes extremely high. So treatment becomes, it's like it's a nightmare for any physician in those cases. However, we need to follow exactly the same standardized things based upon early, primary, secondary, latent, early or late syphilis, and treat exactly in the same way, explaining them the risk of the vertical transmission and the chances of patient having miscarriage.
Sir, about non-gonococcal urethritis.
So non-gonococcal urethritis is the second most common was the chlamydia, as I explained. Chlamydia trachomatis becomes a very, very important when it comes as a non-gonococcal thing. And then we have other like syphilis, which we spoke. Then we have what was it? There are a couple of them more. Though that encompasses non-gonococcal, but the most common when you talk about a non-gonococcal is the chlamydia, and that's what I just covered it.
Thank you, sir. So we also have a session tomorrow, right?
Yes, can we have that at 3 o'clock? It's supposed to be at 3:30.
Yeah.
Because can we have that 3 o'clock?
Yes, sir, we can. Thank
Yeah,
you,
so
sir.
let's keep it at 3 o'clock. Okay.
Sure,
Yeah.
sure.
Yes.
Right. Right. There I will be covering HIV in detail.
Yes, sir. Yes.
Right. Thank you.
Thank you, sir.